Hi, everyone. Dr. Lindner. Let's take a look at the spinal nerves. So in previous video, we went over the brain. We went over the spinal cord anatomy. And we also went through the cross-section of the spinal cord. So you heard me in a previous video talk about the ventral rami, or the anterior ramus, which is a nerve off of the spinal cord. And I said they create plexi. So you could see in the neck, we have a cervical plexus, a brachial plexus. In the lower back, we have two. We have a lumbar plexus and sacral plexus. You also heard me say that in the thoracic region, there is no plexus. We only have 12 pairs of intercostal nerves, the 12 pairs of intercostal nerves. So we're going to go through some of these nerves that are significant and important. Let's see if I can check off a few of them here that I think are important, and then we'll show them in a separate slide. I think the phrenic nerve is important. That goes to the diaphragm. We'll go over the axillary nerve, the musculocutaneous nerve. The axillary nerve goes to the deltoid and teres minor muscle. The musculocutaneous nerve, and I'm not expecting you to kind of write all this down and get it down in one passing, but when you do the playback, you'll be able to get down some of these muscles because they're important. The musculocutaneous nerve goes to your elbow flexors, like the biceps brachii and brachialis. The radial nerve goes to your extensors, the extensors of the elbow, extensors of the wrist, extensors of the finger. When I think of radial nerve, I just think extension from the elbow down to the fingers. Whereas the ulnar nerve and median nerve are going to control the wrist flexors and finger flexors for the most part. Okay, so you're going to hear me refer to this as flat Stanley. It's the name. So we're going to talk about flat Stanley and go over some of the nerves that come off of flat Stanley. But from the cervical plexus first, you see there's a bunch of nerves here. The one that I think is important for you to keep in mind is the phrenic nerve. And the phrenic nerve is going to stem from C3, C4, and C5. So you may hear me say C3, 4, and 5 keep the diaphragm alive. C3, 4, and 5 keep the diaphragm alive. If you search my YouTube channel, I have another video about birth trauma, and I go over how many instances during traumatic birth, when there's pulling on the baby's neck that's a little bit excessive, it can affect damage to the phrenic nerve and affect the breathing, as well as traction and pulling on the baby's delicate spine can affect and create paralysis down the arm. We've seen people that have Erb's palsy of the hand, or they have hand drop, okay, or ape hand, a lot of different deformities due to birth trauma. But C3, 4, and 5 keep the diaphragm alive due to the phrenic nerve. All right, let's look at some of the first nerves that come off of flat Stanley here. On the top of the neck, we have the cervical plexus. So when you see a group of nerves on the top, that's the cervical plexus. What we see going down the arm, that's the brachial plexus. So nerves going upward, this bracket should just be a little bit up higher because it's this stuff going up, that's the cervical plexus. And here is the phrenic nerve from C3, 4, and 5. So this going up and down, that's the phrenic nerve, C3, 4, and 5, keep the diaphragm alive. Okay, going down the arm, we have the brachial plexus. That's from level C5 to T1. C5 to T1. So when there is neck trauma, especially whiplash from car accidents, there could be damage affecting weakness to the shoulder, weakness to the arm. Some people can get what we call radiculopathies, which is shooting pain or numbness and tingling all the way down to the fingers. And there's nothing wrong with the shoulder, elbow, or fingers. The problem is at the beginning of the brachial plexus. So we have the axillary nerve, musculocutaneous nerve, radial, ulnar, and median nerve. These are what we call terminal branches off the brachial plexus. On flat Stanley, here is the brachial plexus going down the shoulder, down the arm, but it's the beginning from C5 to T1. When we look at some of the terminal branches wrapping around right here, that's your axillary nerve. Let's see if I can, there we go. So we have the axillary nerve, which goes to the deltoid and teres minor. We have the musculocutaneous nerve right here. It looks like it's maybe 53, right down the center of the mid-humerus right here. That's the musculocutaneous. That goes like to the biceps brachii and brachialis. Then we have the ulnar nerve. The ulnar nerve is along the side of the ulnar bone, so it's all of this. This is the ulnar nerve. And then on the radial side, we have the radial nerve. So we have the ulnar nerve on the ulnar side, radial nerve on the radial side, and between the two, in the middle, is the median nerve. This is the one that's involved with carpal tunnel syndrome, right down the center, carpal tunnel syndrome. And oftentimes when that nerve gets pinched, there'll be numbness to the first, second, third, and half of the ring finger. There'll be numbness down the first, second, third, and half of the ring finger, the half that's closer to the other three. Okay, now we'll look at the lower spine, where we have the lumbar plexus and sacral plexus. Remember, there's no plexus in the thoracic region. We call them intercostal nerves. Intercostal meaning between the ribs. This is where shingles likes to attack, right? Or herpes zoster, where there's a deep pain following the course of the intercostal nerves. Okay, you can also follow the face as well. It likes to follow dermatomes. So there is one cranial nerve of the face called cranial nerve 5, which is the trigeminal nerve, and it controls the sensation to the face. So sometimes shingles can attack that cranial nerve as well as the intercostal nerves. So on flat Stanley, here's the intercostal nerves. And now in the lower back, we can see the upper part of the lower back is the lumbar plexus, whereas this part is the sacral plexus. So the off the lumbar plexus are two big nerves, the femoral nerve, looks like number 67, that's the femoral nerve, and then the obturator nerve looks like it's number 68. Okay. Femoral nerve is going to go to your quadricep muscles, and the obturator nerve goes to your adductors. Remember the adductor longus, adductor magnus, adductor brevis, pectineus. Those are all strong adductors of the thigh. A little bit lower is the sacral plexus, and the most important nerve off the sacral plexus is the largest, thickest nerve of the body, called the sciatic nerve. It looks like it's number 71, sciatic nerve. This is still sciatic nerve, and the sciatic nerve splits. When you get to the knee, it splits. And the two big nerves that it splits into is called the, let's see, right here, this is called the common peroneal. So it's not labeled, but let's see if I can do it for you. So right here, it's called the common peroneal. And the common peroneal, anytime you see the word common, it's safe to assume that it's going to divide into two things. Okay, like when you do blood vessels in AMP2, you will learn that there's a common carotid artery. And if there's a common carotid artery, it's going to divide into two, an internal and external carotid artery. So whenever you see the word common, say, okay, it's going to divide into two things. So the two things that the common peroneal divides into is going to be the deep peroneal and the superficial peroneal. So the superficial peroneal, let's see if I can outline it. It's going to go like this. Superficial. The deep peroneal goes to all of your dorsiflexors. All of your dorsiflexors of the foot. So like tibialis anterior, it's controlled by the deep peroneal nerve. So the sciatic nerve is made up of A, the common peroneal, and then B, the tibial nerve. Okay, they call it the posterior tibial. So the sciatic nerve is composed of A, the common peroneal, and B, the tibial. A, the common peroneal, can divide into a deep peroneal and a superficial peroneal. Superficial stays superficial. It's this nerve that gets compressed when you sit with your legs crossed, like a figure 4, and then all of a sudden your foot goes numb, right? It's the superficial peroneal nerve, and then because you're compressing it on the outside of your leg, when you sit with your legs crossed, it just numbs it, and it feels like pins and needles. Okay, so back here is the posterior tibial, and then here's the deep peroneal. It's just another view of it. Okay, deep peroneal goes to all of the anterior compartment muscles, like tibialis anterior, extensor hallucis longus, extensor digitorum. Anything that's in the front of the leg that goes to the top of the foot is going to be deep peroneal nerve. And this one begins from L4. So remember, L4 is your dorsiflexor. L4 is your dorsiflexor. L4 is your dorsiflexor.